go. Now, does everybody have one of these? If you hold it up if you have one of these. Oh, great. Wow, that's going pretty quick. Andy, you are a magician. If you don't have one of these, can you hold up your hand? Okay, Andy, there's some folks at the front. And what I'm going to do is I'm going to ask for audience participation on several levels today. One of the levels is if somebody walks in and they sit down and they don't have one of these, I'm going to ask you to take personal responsibility for asking them. You're going to need a clicker. This is going to be an interactive talk today. In terms of even the background for this talk, there's been a huge transition that I'm extraordinarily happy to see coming about in medicine and the funding of medical research, in that we're starting to look at translation. We're starting to look at the possibility of bringing treatments from the bench to the bedside, and some of the most exciting things that I think are happening right now are in the field of stem cells. So Santa Clara Valley Medical Center is one of 3 places in the country now where you can get stem cells for spinal cord injury. Dr. Shaw, who's pictured down here on the bottom, is bringing exoskeletons that use very light battery technologies and very advanced computer systems to be able to allow people with weakness to walk. Those are specific technologies that are happening, and that's fitting into a broader paradigm shift that we want to have mechanisms for starting research and putting it on a track where it's going to end up at the bedside. And in order to do that, the DoD and the NIH have set up a really interesting thought process where they want to start the train of research on a set of tracks where it would go to implementation. So you'd practically be able to start from a moment where you're saying, what's relevant to the community of people that we're talking to, see the patients. Let's ask them some things about the patients that they're seeing. Let's take those ideas, we'll move them into the bench and look at the results that we could potentially get, and then we'll bring that back into the bedside, because if we involve clinicians such as yourselves, and this is going to be an interactive talk, then we may be able to get to answers more quickly rather than not involving clinicians. And this particular collaboration is just fantastic. I mean, who likes the Bay Area? Is the Bay Area pretty? Oh, come on. You guys have, it's sold out, 400 people here. This is fantastic. So this is a collaboration that I have to give a lot of credit to Jeff Manley. He's really done a fantastic job in taking leadership in the Bay Area and across the nation in terms of brain injury. Jackie Brejnahan and Mike Beatty actually came up with an idea that we're participating in right now, which is an idea to say, let's take scientists like themselves and let's start working with clinicians like myself and like yourselves and try to bring some of the ideas about these dual diagnosis patients out of the community into a paradigm where we can look at these patients. Graham Creasy, who has a medal around his neck here, was named the National Paralyzed Veterans Association of America professor. And he actually had this fantastic idea to start the Stanford Partnership for Spinal Cord Injury and Repair. That's an idea that across a variety of institutions around California, especially in Northern California through these 3 groups, that we might be able to do exactly the sort of thing that we're doing today, which is foster collaboration so that we could get new ideas and new treatments actually practically to patients very quickly. So the outline for what we're going to talk about today is we're going to talk a little bit about mild brain injury in the context of patients who have spinal cord injury, and we're going to actually ask you some questions. That's why you have these clickers, and we'll get to practice with them. And then we'll talk about a case that's a little bit more complicated that starts to raise some questions about what should we do, what mechanisms should we have in place, and what should we be thinking about for patients with dual diagnosis as it gets a little bit more complicated to make sure that we're, like we're saying, going down the right track. We're going to take the ideas over the next 3 years, so you're actually involved in potentially 3 years of looking at some of these ideas. And right now we're going to ask some questions. A year from now we're going to look at some of the answers that come back from the bench. And in the 3rd year we'd like to actually be able to bring some of those potentially into clinical practice. A big question for us today, and in the next 3 years we're not even going to attempt to do this, we're just going to set up potentially a framework for asking the question, would it be practical, would it be relevant to have a guideline, not this guideline, not the acute spinal cord injury management guideline, but perhaps could we, by the time 3 years is over, know enough about where we would want to go for a guideline overall for dual diagnosis? And ask the question, how many people think that would be interesting, and would it really be practical and relevant to the clinician to do that? So the talk today is going to be very interactive. Uncle Sam is pointing at you. Everybody have their clicker handy? Yeah? Is anybody here and doesn't have one? Raise your hand. Yeah. Okay, so can somebody get this nice person? Andy Droggle on the spot. So you are going to participate in this in a structure that you're going to understand a little bit more concretely here in a minute, where we're going to put in answers, and then we're actually going to discuss a little bit. I have a microphone on. You guys will probably have to speak up a little bit. We're going to talk about the answers that we actually see, and you're going to have to participate in it. The methodology, I'll basically read the question. Despite the fact that you have this, it's going to be anonymous, so no particular, don't feel like there's any pressure. You just answer the question the way you feel. And this is not aimed so that I'm not only asking if you're a clinician, if you have an informed opinion about the questions that we're going to answer, I'd like for you to answer the question with your honest opinion. In fact, I'm even going to ask some questions later and invite some participation from people who maybe don't necessarily even directly see patients. The results are ultimately going to be available through a site that Ann Perkins has done some wonderful work with. I just saw the movie Social Network. Did anybody see that one? The Academy Awards are coming up very soon. You need to get through your queue of movies on Netflix. So Facebook VMC Rehabilitation has a lot of information about the things that are happening at Valley, and you'll be able to find some of the results there. Okay, so this system will allow you to put in a response 1 through 10. 10 is actually 0 on the keypad. And if you change your mind, just put in a different number. It's only going to take the last answer. So if you say yes at one point and then you think about it, you're going to have 10 seconds at the end. You say no, well then just put in whatever your last answer is, and that's all that's going to show up. So let's actually try this. You guys ready? Everybody have their clicker. So we're just going to ask a really simple question. What's your favorite color? Red is number 1, blue is number 2, green is number 3, yellow is 4, and purple is 5, despite the fact that's my favorite color. And let's go ahead and start. You'll see a timer, if this is working. All right, go ahead and put in your answer. Oh, that's interesting. Okay. So fantastic. So this is exactly how the presentation's going to go. We're going to get responses like this that will show up automatically, and then we're going to talk about some of the responses that come up. Okay? So for the first question, this is basically your background in terms of training. So we'll get an idea, sort of a poll of the people who are in the audience. You don't have to put in your answer yet because we haven't started the timer. But I like you guys. You're into it. You're ready. This is definitely going to work. I apologize ahead of time if I didn't get the exact type of training that you have. You can always use other, which is going to be 0 for 10, and we'll have 10 seconds. So just put in your response, and we'll see. Yes, the timer started, so you have to go ahead and put in your response. Fantastic. So it looks like, just so you guys know, if you look to the left and right, 1/3 of the people in the room should be RNs. About 1 in 8 people would be physicians, physical therapists, occupational therapists. So this is sort of interesting. There's an interesting breakdown of the people who are here. So 2% of the audience is attorneys. Can we have the attorneys raise their hands? Fantastic, fantastic. Okay, so now we're actually to the serious sort of business of the talk, and what we're going to do after we answer this question is we're actually going to take some time, and I'm inviting anyone who feels like they'd like to say something after the question is over to engage in the response, and I might end up sort of pulling some people out based on some of the different responses that we have here. So the general context for the question is there are patients who have spinal cord injuries, and sometimes maybe in the environment of a hospital, their brain injury isn't necessarily that obvious, especially for some mild brain injury. And then they might make it home, and then there could be some percentage of those patients who've made it home after their spinal cord injury who have mild brain injury. So the question is, how often is mild brain injury first diagnosed after spinal cord patients are discharged home? And the responses are going to be less than 1 in 10 patients. You'd see that in, so that would be less than 10%. 1 in 10 patients, so about 10%. 1 in 5 patients, which would be about 20%. 1 in 2 patients, which might be as high as 50%. 4 out of 5 patients could be as high as 80%. Or, perhaps this is happening even more dramatically than that, even more than 4 out of 5, so more than 80%. Does anybody have any question about how just what the question is framed as? Or?
Dr. McKenna, I just want to say, you may have already covered this, but you're not expecting people to have direct knowledge of this, even if it's a best guess. You want people to go ahead.
Yes, that's exactly right. And the background, that's a fantastic question, Ann. So the background context for this is that different people have made very valiant efforts that have looked in a variety of different circumstances to try to address some of these questions. Shepherd, under Dr. Machaki, has done some fantastic work looking at these sort of things, but we are actually seeing these patients. We're practical insurance providers, attorneys, physicians, nurses, therapists, so our opinion matters about this. And even if you're not necessarily directly seeing them, but you have an informed opinion about it, I want you to make your best guess about how often you would think this is actually happening. Any other questions about that?
I just wondered, is it home or would you include nursing home or
I'm really thinking more home, and I'll tell you a little bit more in the discussion piece about why that is. So say you've been in inpatient therapy, you managed to actually make it to a discharge in the community. How often would it be that person would at that point be diagnosed as, would it be noticed after, or diagnosed sort of after the fact? Yeah? Those are all fantastic questions. And this is designed to be interactive, so I'm already getting the interactive piece. Fantastic question. So this is after they've finished their rehabilitation stay. They've been in rehabilitation for their spinal cord injury. They've improved their FIM. They're ready to actually go home. But at that point, we're diagnosing them with mild brain injury. Okay. All right. So everybody ready? You have your clickers handy? All right. And we will start now. Yeah. Fantastic. So, so we have a fairly broad breakdown across a variety of different commonalities that this would come up. And so I'm going to open it to the audience. Does anybody who had a response here want to say something about that? Yeah, these are sort of spectrums of part of the, it's part of the same process that maybe as it's getting shorter, maybe we are diagnosing it, maybe we aren't. Maybe we're actually bringing some of our own skills. And we've got techniques for dealing with brain injury, but we're not necessarily formally making the diagnosis so that we're setting up a specific program around it. Dr. Englander?
Yeah, if you read acute emergency room and admission history of physical data on documentation on people with spinal cord injury, they'll say what the Glasgow Coma score is, but they'll never say how they, whether they've done an orientation log or an amnesia test, to ascertain really whether the person had a brain injury even that resolved in the time it took them to get to the acute care hospital. Everything is focused on the spinal cord injury, which is understandable because that's a life-threatening condition. And unless the person, so the milder TBIs are not going to get picked up by emergency room folks, period. So, and even in centers of excellence, there is a tendency to just focus on the spinal cord injury often, and not to actually do a test of amnesia that occurred. So I think it's under-recognized.
For the person, if someone's willing to actually answer this, so if you said it greater than 80%, yeah.
My experience has been outside of the spinal cord injury. The mild TBI is ignored. Practitioners never see it, and nobody ever spends the time that it takes. The 15-minute standard meeting with the physician, this goes past the boards, and it's reassurance, everything will be fine. So I voted that it was a very high percentage because you always focus on immediate needs, and I'm interested to see what the answer is.
I think it would be interesting to know the cervical cord injuries versus the lumbar cord injuries, because you almost want to say there's a few cents over here in every cervical cord.
Were you in this higher?
I wasn't.
It's fine. It's anonymous, actually, by the way, so sorry to put you on the spot. Yeah. Yeah.
Well, you didn't say cervical versus lumbar, so I don't know.
Yeah, and this is exactly the format to discuss some of these things, because as we start to talk about what models would be appropriate, you know, there's a very potentially complicated interaction if we were thinking about what a bench scientist could do in terms of what types of injuries they might be studying, right? They might be studying a thoracic level injury because that's maybe easy to study, but this is the classic problem of looking under the street lamp for your keys, because that's the easiest place to try and find something. That's not necessarily where, you know, the answer is going to be.
I would say that as a therapist working with somebody, we'll see spinal cord injuries, and they may be a little off. Well, not knowing that person on a regular basis,
Yeah.
you know, that it's the family who knows what their typical personality is, what they're like. We don't know what, you know, everybody's a little different in their personality. Some people are more forgetful, some people are a little off, and it's like, well, maybe he got his spinal cord injury because he was a little off to begin with, and it's at a higher risk type situation.
Yeah.
So we are always saying, no, there's a little something different, and the other thing, we don't know how much of the meds that might be contributing to some of that offness. So I could definitely see where.
Actually, even on that, I'm going to come to you in 1 second. Then we can keep going. This is fantastic. You guys are wonderful. I'm really appreciating this. Sort of another view on that also, and people have raised this question, is the environment of inpatient rehabilitation a relatively sterile environment? Are the number of stimuli that we're running into not necessarily diverse enough to recognize some of the limitations that people are going to run into when they get to the grocery store? Because a grocery store is a lot more complicated than Valley Medical Center's inpatient rehab center, for example. So, you know, I think that there's potentially opportunities, and there's potentially even just insight into, you know, potentially why we aren't necessarily seeing some of this. There's a, yeah.
I work with people who are more subacute as a neuropsychologist, and so in the course of therapy, you know, comprehensive OTCT, speech, whatever, symptoms suggestive of MTBI may start coming up. But the other thing I want to say is that the patient who has spinal cord injuries, that is their focus. At least that's my experience. You know, unless it's more severe for them brain injury. And so, you know, I think there's a little bit of a, maybe we collude, you know, with the fact that it doesn't seem so important.
Yeah, and I've also heard another comment along those lines about, you know, perhaps it's relatively easy for the practitioner to, they might already have the skill. I mean, they might just inherently have been working with people that had brain injuries, and they, you know, maybe it didn't rise to the point where they were going to put a label on it and say that. So that especially for thoracic level spinal cord injury, as the gentleman in the front was bringing up, that person is going to have, they could learn a vast variety of care strategies. And if we didn't give them tools to deal, say, with frustration, if that was the manifestations of their brain injury, they might not actually make it as far in their therapy if we weren't thinking about, you know, we need to formally make sure that they and their loved ones our caretakers are in a position to have strategies to reach their maximum potential. Yeah, no, that's a fantastic comment. I'm gonna take another question, and I noticed that there are a few Stanford residents from the program here, so we might even ask if they have any questions. But go ahead.
Yeah, being exposed to psychiatry, and it can get somewhat, you know, confusing whether this behavior would be psychiatric or actually brain injury and have to do an intensive therapy.
Yes, or maybe an intensive diagnostic strategy. And perhaps, we're not going to get into this that much today, but also even the question, would the medication choices be different or more specific based on what I think someone had mentioned their prior cognitive state had been, or even more specifically, whether we think there's, Roberta Wong, who I think who's met Roberta Wong or seen a talk from her? A few years ago, I was talking to her, and she just had an unbelievable insight into something exactly what you're saying, which is that in some systems, you're labeled as a mind, the main underlying issue is a mind issue. or the main underlying issue is a body issue. So there's this practitioner division of mind versus body, but in practice, in real practice, the mind and the body aren't actually separate. So you need a way to actually bring the practitioners together so they're addressing both of those things at the same time. And it might be that one is more the other, and her frustration was that if somebody got labeled as being more on the mind side, it was difficult to get the body practitioner, the MD, in there, and if it was more labeled as a body-brain structural issue, it was difficult to get the psychology in there. So that it wasn't that obvious to me that this was happening, and as I got further on in my career, it became a little bit more obvious that this was an issue, and now that I'm a little bit further and taking sort of the pulse, I think that from a physician perspective, it can be very much, I see the thing that I'm sort of treating, and I'm not picking up the broader sort of interactions that TBI will often fall into. And just one thing in terms of when we answered our question earlier about the breakdown of our specialties, we're actually going to be able to stratify the data after the fact and look at, do MDs tend to think that this is less common? Are there trends across specialties where one group tends to maybe underdiagnose this more than another? And that might be an opportunity even for structure for education for physicians, or how to get therapy, psychology, speech therapy, to be able to bring that to the physician's attention so that we can more accurately drive some resources. Well, so that's fantastic. That was the first question. And now this one, the intent here is that if you have now or in the past, if you take care of patients and you are seeing your answers coming from a perspective of a clinician, do you feel like you're answering the questions as a clinician, or do you feel like you're answering the questions as an expert whose opinion is informed by a variety of other pieces of information? And part of the reason for this, and maybe I shouldn't tell you this before the fact, but I really want to know what the people who are not clinicians think as much as the people who consider themselves clinicians. So you're not getting stratified as more important or less important. This is more to sort of figure out how we can make sure that we get a balanced discussion. Does anybody have any questions about this, what this question means? Okay. So we will start. So put 1 if you believe you're more on the clinician side, 2 if you believe that you're not on the clinician side. Here we go. Okay, all right. So remember, I'm gonna, for the people who put in the non-clinician side, I'm gonna invite your input on some questions that, we're about to move into something that it may seem more clinical. We're gonna actually talk about a case, and then talk a little bit about how we would divide up some strategies for care. So this is actually a real case that we saw at Valley Medical Center that was actually much more complicated than what I'm going to mention in these slides. But I wanted to keep it in a broad enough context that we can kind of sort of address sort of a practical question. So this is a 63-year-old male who came in with a brain injury and a spinal cord injury after a motor vehicle accident which happened on city streets. He was unrestrained at the time. He had significant injuries that we'll get into a little bit, but he was not ejected from the car. When the paramedics came and evaluated him, initially he was somewhat somnolent, but you could just talk to him and he would open his eyes and interact with you. He seemed a little confused. He wasn't necessarily giving completely appropriate responses at the time, but you could ask him to do things, and with at least his upper extremities, he could pretty clearly follow commands. When he got to the emergency department, it turned out that he had fairly significant radiologic evidence of brain injury with a subarachnoid hemorrhage and a subdural hematoma and cortical contusions. So it turned out that he had 2 burst fractures in his thoracic spine, T3, T4, and the CT findings that I had mentioned. He was intubated, and actually over the course of his care, he became very, very sick. He actually started to herniate. He was instituted with some neurocritical care protocols, including a ventriculostomy, hypertonic saline, cooling. By day 15, he was not waking up and really following commands in a way that we would normally expect. So he had a tracheostomy placed, and he had a percutaneous gastrostomy tube for feeding. There were some attempts to wean him off of the ventilator, and interestingly, despite the fact that he was recovering from his physical injuries, it seemed that maybe he wasn't necessarily responding with a normal respiratory drive. So he was transferred into the center which I run, which is the Rehabilitation Trauma Center. So he was physiologically stable. He wasn't on pressors, he didn't need telemetry, but he was very complicated. There were several very complicating factors in terms of how to manage his ventilator. So he was still completely ventilator dependent at the time that he arrived. Over the course of 30 days, we did a few things, including therapy strategies that just established his circadian rhythms, getting him in and out of bed. Some medication choices were made so that he was able to come off of the ventilator. And by day 50, he's now completely off the ventilator, and he's admitted into Valley Medical Center's rehabilitation service. So the Rehabilitation Trauma Center where I work, despite the fact that, and I'm the chief of, despite the fact that it has the word rehabilitation in the title, it's actually an acute care unit that's licensed as an ICU. It's a medical ICU. But it's a very nice place to initiate many of the rehabilitation strategies and get somebody put into a rehabilitation center where many of you've avoided contractures and bed sores, and you've brought therapists who know quite a bit, who know a fantastic amount about therapy, and started the program. At that point, he had O-logs actually that when he originally arrived, he couldn't even really complete, and by the time he got to day 50, he could answer the questions in an O-log, but he would only get to about 20 at best. He wouldn't get to 24, so he was still in post-traumatic amnesia. He still had a tracheostomy, but the cuff was down, and he could talk, and he would say things like, he would get very frustrated, and he would say things like, "I feel all scrambled up." He had still the T3 Asia B spinal cord injury, and after having gone through some fantastic rehabilitation, he was actually able to be discharged at day 90. So for someone like this, one of the questions, and now we're going to get back into the dynamic response. So you guys, lunch hasn't happened yet. We're all energetic. We're ready. We're going to participate. When you think about the team, that's going to potentially be the most appropriate team for a patient like this who has paraplegia and a brain injury, a very significant brain injury. Would you strongly favor a patient like this being taken care of by a brain injury team, or moderately favor a brain injury team? Think that a brain injury team or a spinal cord team could pretty much equally take care of a person like this? Favor a spinal cord injury team, or moderately or strongly favor a spinal cord injury team? We've got some laughs because it's a tough question, right? Yes. Yes, he has. Yeah, he's T3. He has full arm function. And he's B, so he has bowel and bladder issues. And maybe what we should be thinking is, should we be doing more cross training? But in practice, it seems to be that most teams consider themselves. I would put it in the context that most teams consider themselves, I'm a brain injury team or I'm a spinal cord injury team. Right? So that's the context for the question. Okay. Wow. Yeah, fantastic. Okay. So if we just open it up for discussion.
This is a biased audience. You need to take this talk to it in the spinal
That's absolutely true. Yes.
In some environments, though, the whole environment's different if you're on a spinal cord unit versus in a brain injury unit. So that's something else to consider.
Mm-hmm. Mm-hmm.
I think it also matters in your specific situation. Like our TBI team, they also have experience in spinal cord in previous jobs, but also looking at once the family comes in, seeing which personalities they match better with, whether they match better with the SBI team or the TBI team based on the patient.
Mm-hmm. Mm-hmm. Yeah. Mm-hmm. In the back?
Well, for me, I was thinking about learning. And thinking, if the person can't remember and they can't follow through and they can't really get it, helping them with their TBI, and he says he's really scrambled up.
Mm-hmm.
So that would be my first area.
Mm-hmm. So, and can you say anything more about, like, practically how that would happen?
I'm not sure what you mean.
So in our center, and I'm not going to tell you exactly where he ended up with us, but there's a multidisciplinary team that goes to the bedside that would be in the rehabilitation trauma center. So while they're still in the acute side of the hospital, so physically they're connected by a hallway, although they're technically licensed as different units. And then there would be a multidisciplinary team that would say, okay, let's talk about this and say, you know, how would this person work in this environment or a different environment? Because we're physically, this is actually Michelle's point, we're maybe a fairly large center, so we're physically divided, and the structure of the facility is set up actually quite different. I didn't phrase the question as the unit that a person would be on, because I know that the audience may not necessarily be in a center that would be so large that you'd have separate units, but still often we would be thinking about things in terms of teams. So that's my lead-in to ask you the further question, mechanistically, how would that decision be made where you are? And there was a comment in the front.
I'm kind of looking at, I'm a nurse, but I'm looking at this probably as a family member. I strongly favor the TBI because to me, my kids or my husband's mind would come first before the body. I feel like I could manage better taking care of them with a spinal cord injury, but if the mind was gone, that would be just so sad.
Yeah, well, wow, that's I hadn't actually thought about a context, but one of the things what you're saying even raises in my mind is when a person is being managed by a primary spinal cord team, it does seem like the focus is patient-centered, and when a patient is being managed by a brain injury team, it's still clearly patient-centered, but there's a more explicit, the family is really where the dynamic is to achieve the function for that person, because you might have a really difficult time getting the person to a place where they're going to learn those types of care. Yeah, that's a great comment. Yeah, and this is a thoracic level injury, so somebody who, yeah, right. I won't steer it. There's a lot of comments sort of building up back here. How about in the back?
I think we'd also want to look at to what degree is the cognitive impairment.
Yeah.
And are there behavioral issues? And do we on the spinal cord unit have a speech therapist available for some cognitive work as well as a psychologist? And I think what others said about looking at the whole total, the family, the age of the person, how much stimulation they can handle, and what our units are like at that particular time.
So your comment, you might be able to bring that out more specifically as how is their brain injury manifesting itself? Which is maybe the primary component of it? Because they might be sort of, they might be more on the agitated behavioral aggression sort of side, or they might be more bradykinesia kind of side.
You know, this all blurs when you get 100 miles out from any urban center, and there is no TBI spinal cord injury unit, and they're on a rehab unit.
Yeah.
And they are on the rehab unit. It has 10 beds, and all the therapists treat everybody.
Yeah, and maybe a paraplegic patient, a patient who has arm function. Well, you just need to fit them with a wheelchair, and then they're going to go home, right? So why would they need to go? Why would they need to go to a specialty center?
There's that possibility. I'm just throwing it out.
Donna, and we'll come back. We're going to come back. Thank you.
My thought process changed as I went through, and I just wanted to share that. I always, when Dr. Englander asked me, I do patients on site in the acute care facility, I do the assessment. And when he asked me, should they go to spinal cord or should they go to brain injury, I'm thinking at it from which one do they need the most care of right now? But as I looked at that, and most of the time I'm arguing with myself about where they should go. But when I looked at this for a minute and thought about it a minute, my old background of working with people in the community that are brain injured and seeing the long-term effects, that what that family needs is support for the brain injury long-term. They'll take care of the spinal cord, especially a para. That's going to be taken care of. But the long-term problems they're going to have are the head injury. And so I think they need that foundation of support for the head injury for the long-term, and the spinal cord they'll get.
Yeah, perhaps you could clearly live in the community with a spinal cord injury at this level, but maybe you might have a hard time living in the community with a severe brain injury that hasn't been addressed.
Right.
Something interesting in Missouri is we have a very small unit, and the team conference is so valuable because there you have everybody there is direct in contact with the patient, and just to listen to the speech therapist, learn the goals and what's going on there, the cognition problem, and with the other therapists, what their goals are for that patient, it really helps nursing know and to follow up and to reinforce everything that's going on. I just think that's a great.
And there might be more cross-training in a smaller center. So the idea of bringing a memory book in a unit that has brain injury and spinal cord injury might even be more natural. And I'll be honest, I mean, that's something even with the Rehabilitation Trauma Center, getting to the concept where we primarily managed spinal cord injury for a long time, and we managed quite a bit of brain injury, making sure that we're doing things. I've worked with Michelle on this same topic of maybe we should be getting more memory books in for patients earlier. Let's think about this. Let's have dual diagnostic strategies introduced at a very early level before they're even in a technical rehab setting. Going around in the back. Yeah. Okay. So, fantastic. You guys are wonderful. The two questions I'd like to do. One that I'm going to keep open for discussion is this question about modeling, whether your thoughts about whether modeling is going to work. And then we're going to go back, and then the last 2 minutes we're not going to discuss it, but we're just going to say something about whether you think a guideline would be practical. Okay? So we're getting down to sort of like 5 minutes now. So for the modeling question, clearly we're more on the clinician side if you look at even the first sort of slides that we put up there. And this is a collaboration with clinicians and scientists. I mean, Mike Beatty and Jackie Brejnahan are world-leading scientists who have just an unbelievable number of skills. Jeff Manley's group, we're incredibly fortunate to be able to work with these groups. Now, if we think about this question, we've just talked about a lot of complexity in terms of the patients and environment. So if we brought some of the strategies that we're talking about contextually, and it's surprising what can actually happen, do you believe, and this is going to be the question, that demonstration of therapeutic effects with some of the different strategies that we might be able to do in a mouse model of dual diagnosis of spinal cord injury and brain injury, would that be sufficient to alter clinical practice? And we're going to ask whether you strongly agree with that, moderately agree, neither agree or disagree, moderately disagree, or strongly disagree. That would be, say, for example, a model that would have Mike and Jackie came up with a model that's used to look at the recovery after stem cell therapies. So if you look at the BBB scale, which two of the Bs are Mike and Jackie, that's a way to say if you put stem cells into a spinal cord from a mouse, how much are they going to be able to walk after the fact? So they've already done that. So then the question is, if a mouse also had a brain injury, would we be able to figure out anything that would then be strong enough to motivate us to change clinical practice? Okay, everybody ready?
One of the most important things that we do as humans is communicate over time. Yeah, the memory, mice can learn things, I'm sure, but the communication and behavioral interactions, I think, are the most important part of what we do as humans. And I think I don't know enough about mouse research, but I think it's pretty hard to measure mouse communication. For humans to measure mouse communication, mice might be able to do it. And behavior, I don't think there's a correlation to that. So I think that's the most challenging part of recovering from a brain injury, and that's not going to be able to be measured very well in the mouse model, in my opinion.
I'm actually going to do the 4 o'clock talk later today.
Yeah.
But,
yes.
I'm going to take you to the metaphysical world where animals belong essentially in a group karmic experience where individuals have individual karmic propensities. So a mice brain is a mice brain, but humans just change the context of the life form, if you will, in my opinion. You can hear more about that at 4 o'clock.
Yeah.
Well, I'm a physical therapist, and I've actually done strength testing on mice.
Yeah.
But I cannot imagine how I could, and that was all just to test certain medications to see if it would help with like normal muscular dystrophy.
Right.
I cannot imagine trying to do a therapeutic thing on a mouse to see if a mouse had a head injury, how I could help it So
Mm-hmm.
I can't even imagine.
Uh-huh. Yeah.
Some of the mice studies, and I'm not a scientist, but I try to read journals and keep a little bit on top of it. And some of the mice studies are really interesting. They're intelligent choices.
Mm-hmm.
You give them the options, and I'm not sure if it's mice or other low-level
Mm-hmm.
animals, but boy, there are a lot of them, and you can run multiple courses, and it's less expensive, and you have to do that anyway to have a foundation. And it sounds to me like it's a great way to start.
Mm-hmm.
But I have to say that Dr. England is thrilled with that.
Well, yeah. So I can say just really quickly, and then we'll do one last question. There are models where you can have a sort of a water maze. So you have an open space, and you can test memory by having the mouse swim to a platform where they know where it is. And it's kind of along the lines of watching people try and draw lines across dots and do tracing tests. So it's, when you actually start talking to the people who understand animal modeling, it's unbelievable the analogies that they can do in terms of, if you were saying hippocampal function, which is what they would be talking about, if you could see that a person had primarily a hippocampal memory forming deficit, you might not give the animal the same test, but it's surprising how many overlapping tests there are for those at least structural abnormalities. So that's interesting. So we'll do the last question really quickly, and then we'll break right after this. And this is the question, is there a need for an evidence-based consortium statement on the management of dual diagnosis? So strongly agree, moderately agree, neither disagree, or agree, moderately disagree, or strongly disagree.
What context are you using?
Yeah, no, that's a great question. So would it, if you had a brochure that said if you're going to manage a brain injury, can you even imagine a world where it's going to have information that you would want to pull it off the shelf and actually look at it? And it may or may not, I mean, one of the points you might make is maybe it isn't going to contain, I don't think it's going to be able to contain something that I'm relevantly interested in. Maybe it could, I won't get into too much of what I think it could be in there, but. Mm-hmm. And that's, well, I'm not going to steer the audience. You guys ready? Great. All right. Well, thank you all very, very much. I really appreciated your participation. Fantastic.